Yeah, good morning. And I want to welcome you to the 23rd Annual Wall Street Comes to Washington Conference. I'm Paul Ginsburg, Director of the USC Brookings Schaeffer Initiative for Health Policy, which is a co-sponsor of this conference. Many years ago, shortly after beginning the Center for Studying Health System Changes site visit studies on changes in financing and delivery of health care, I perceived how poorly informed federal policymakers were about what was happening on the ground in healthcare markets. And I also perceived, through friends, that Wall Street analysts were conducting their own research on these issues to inform their investor clients, and that policymakers could also benefit from the analysts' broader market perspectives. So after convening an meeting with analysts in New York in a very private setting, I invited them to come to Washington the next year to have these discussions in front of a policy audience, initiating what's been an annual event for many people inside the Beltway value for its outside the Beltway perspective. I'm delighted that the Jane Koskinas Ted Giovannis Foundation for Health and Policy recognizes the value of this conference by funding the event for the 6th year. And through research and projects like this conference, the JKTG Foundation hopes to foster discussion about cost reduction, expanding access to care, and improving quality. So the conference's main purpose is to give the Washington health policy community insights into market developments that are relevant to policy through equity analysts. And this year we also have a DC-based policy analyst who advises institutional and other investors about the potential impact of government policies on healthcare companies. Along with a thorough understanding of healthcare markets and the companies they follow, all of our analysts today closely follow public policy because of its implications for publicly traded companies. Our format this morning, as it's always been, is going to be a roundtable discussion based on questions that have been shared with the panelists in advance. And we'll have two opportunities for audience Q&As, the first before we take a break at 10:30 and the second before we adjourn at noon. And note that the analysts are not permitted by their employers to answer questions about outlooks for specific companies. And a transcript and webcast of the conference will be available through the JKTG Foundation website later this week or early next. And before you leave today, we'd appreciate if you would take a moment to fill out the evaluation. It's in the left-hand pocket of your folder, and leave it on your table or on the table outside the meeting room. We have a great panel this morning. We have two veterans of previous Wall Street Comes to Washington conferences, Matt Borsch of BMO Capital Markets and Anna Gupte of Leerink Partners. And our third panelist is Paul Heldman, who, while new to the panel, knows the event well, dating back to his days as a reporter covering health policy for Bloomberg News. Paul now has his own firm, Heldman Simpson Partners, which advises investors about government policies that may impact their healthcare holdings. So what I'm going to do today is spend a lot of time at the beginning about what I think is the most interesting developments over the past year, which is all of the initiatives towards vertical integration in healthcare financing and policy. And the first question is that in the past year or two, we've seen many proposed transactions, some of which have been approved, seeking to achieve vertical integration among healthcare companies. In many cases, the strategies behind these combinations are not clear, at least to those outside the organizations involved. But when they can be discerned, they often provide insight into long-term potential trends in healthcare financing and delivery. And public policies, either implemented or anticipated, are a potential motivator of some of these transactions. I will ask about the strategy behind a number of different types of vertical consolidation generically. And if you want, you can bring up specific examples. So the first type of vertical combination I'd like to discuss is the integration of large pharmacy benefits managers, or PBMs, into insurers. And the possible strategies include more seamless access to drug claims, which provide more insight into patient issues than medical claims do, or avoiding the challenging contracting arrangements between insurers and PBMs. So I'd like the analysts to discuss what they see are the strategies behind and the potential of and barriers to insurer-owned pharmacy benefit managers, period. Actually, I'll get into my details later. And who would like to start?
I'm happy to take it.
Okay, Anna.
Okay, great. So I think the PBM industry, or the PBM industry as it stands today, standalone PBMs, which really we only have two large ones, Express Scripts and Caremark, and the deals are poised to close in Thanksgiving. To me, they feel like they've just gotten bigger and separate from managed care never really ever made sense, and I think from the point of view of either the member or the patient, the point of view of the provider, and even most importantly, the point of view of their existing employer and government clientele. And there's always been an imperative to vertically integrate pharmacy benefits into medical, because the pharmacy benefit is just going to influence medical cost and utilization, further down the care continuum. So why would you have a different entity managing that member, through one benefit, while hospital, outpatient, and other benefits are managed, by managed care? And in fact, I used to work in Aetna, a long time ago now. I've been on the street for over 10 years. But in 2005, I remember Ron Williams, who was the CEO of Aetna, had a very, very strong vision at the time of vertically integrating all benefits, pharmacy particularly, but behavioral as well, and then also disability, life, and so on into the medical benefit. The problem was, at the time, we only had mostly the commercial employer market, so there wasn't enough scale for any of these players. It was far more fragmented, and they were not enjoying the benefits they have right now of growth in Medicare Advantage and growth in Medicaid through managed Medicaid and privatization. So when Aetna tried to do that, and they did have an in-house PBM for quite a while, they did have issues around scale, getting the best drug rebates and discounts from the drug manufacturers. They even had issues at the time around mail order fulfillment that met the necessary quality standards, and at some point it was impacting their reputation in business in the employer markets as well. So they chose, after a long period of resistance, to outsource to CVS. Anthem outsourced to Express Scripts, but Anthem was under a very difficult phase in their history around execution, and they were in a state of turnaround, and they just wanted to farm out at least one piece of the business so they could focus on turnaround in medical. And then Cigna kind of took a middle ground. Over time now, we've seen growth, as I said, in multiple payer mix areas. And United realized, and I think United and Humana had that benefit more than anybody, because Medicare Advantage and Part D were the benefits that they really grew outside, got outside share gains in. So Humana had their captive PBM in-house, and now have close to 500 million scripts, which is quite remarkable, for for their own business. And United brought the Medco business in-house in addition to their Medicare business, and have really, I would say, quote unquote, shown the way. This is what is possible with an integrated PBM, with Optum Rx under the same umbrella as managed care. They're growing share outsized. They're expanding their margins. And here you are, Cigna and Aetna, and you're finally kind of saying, well, this is not the best place for us to have an outsourced PBM. Simultaneously, Express and CVS have been under a lot of scrutiny because of their revenue line, because they get their revenue on a spread on what the benefits, drug benefits they manage, which is completely misaligned with their end customer. And the government is now pointing fingers, of course, as you all know, with where rebates are going, the difference between gross and net pricing. So here you have an imperative from both sides to come together and sort of become a fast follower, if you will, to United and Optum. So it makes a lot of sense. I'm very bullish on the deals as far as the PBM goes. So particularly Cigna and Express, which is largely about integrating the PBM and managed care, and then at least the Caremark portion of CVS and Aetna. And then on the physician side, specialty drug spend is going to be close to 45-50% of total drug spend. So you need control of the physicians. That's the other reason. Beyond the employer alignment and the member alignment, it's the docs. And all of the managed care companies have contracts with oncologists and rheumatologists and other specialists that are driving injectables. So they can influence utilization. They can hopefully piggyback on what the government is doing around Medicare Part B, where they're trying to eliminate the whole buy and bill distribution model in the doc's office and move to flat fee. Would Express Scripts and Caremark have been able to do that? They have no control over the docs. They have a few infusion centers. That's something that they can do, I think, going forward. So they'll be bigger, they'll be integrated, and I think it's a new big five. It's ushering a different era.
Yeah, and let's get into the docs a little later on. Paul?
Just to quickly build on what Ann said, I think, tell me if you disagree, but really what we have is the rise of drugs as a percentage of the premium dollar, driven by specialty drugs. So it makes these vertical integrations even more imperative from the company's perspective.
Yeah, I still like to dig in a little bit more about,
Paul, can I
sure.
just make one point, because I agree with the comprehensive presentation that you made, Anna. I would just add a couple of points, which is you have this. It's been something the managed care industry has wrestled with, in that the PBM has emerged as a scale entity representing multiple plans in a function that is very scale sensitive. Now, the very largest managed care companies have become big enough where, with their own business alone, they can pretty much get there in terms of scale, and then of course they can do business for other health plans that don't have the scale. And there is a large, I don't need to tell you, but there is a large percentage of the industry that is not going to be in those, inside those big three arrangements that are now owned by the big three managed care companies. Structurally, they don't have the scale to support their own PBM. So they now face the dilemma of contracting with PBM. They're really, the 80% of the market share is now held or will be held by PBMs owned by their largest competitor. So this is something that they may be perfectly comfortable with that. Some of them, I know not all of them are, that that they perceive that that function, while they may be willing to buy services, that actuarial services and things like that from Optum, that the PBM function is closer to the heart of the business. So it's going to be interesting to see whether the regional and smaller plans get comfortable with that, or whether they feel so strongly about it that they end up supporting there are other alternatives, and some of the market share might shift as a result of that.
Yeah, so actually you were getting into what I was going to do. So we had the situation, say, 15 years ago, and as Anna mentioned, a lot of the insurers didn't feel they had the scale to do a PBM, so they outsourced that function. And so of the things that happened, I wonder how much of it is, say, innovation. The innovation that United started innovating through Optum with being able to convince other insurers that they could contract with it for PBM services. And maybe another innovation is seeing the value of the flow of the prescription claims data and its value for medical management. I don't know, what are your thoughts more about what changed during this 15-year period?
Yeah, and actually, though, I will point out the irony here is that, if anything, that the physical the organizational integration of a PBM and a managed care company, in theory, should be perhaps less important, just given how much better the IT interfaces have gotten in terms of data sharing and so forth. Albeit, I recognize there's still some significant advantages, I'm sure, to the organizational integration. But that's the other side of it, and I'm not sure I have the answer to that question.
Yeah. So in a sense, now it's actually somewhat more seamless with a separate PBM if you're a smaller insurer, as far as that PBM's feeding you data on a real-time basis.
Yeah, back to your point, I guess, on the Chinese wall is, I suppose, something you talked about that in terms of Optum. Optum ran I think this was Steve Hensley's vision, to run an organization that not only serviced its internal needs, but was able to be perceived as an independent, neutral, confidential vendor for third-party benefits management. And they did that, they did a good job of that, building IT systems and firewalls across UHC, the managed care organization, and Optum, rebranded Optum as Optum RX, and have had some pretty remarkable success in achieving satisfaction from third-party health plans. So that's one element of innovation. I think the other element of innovation is that the pharmacy benefits managers, they manage the formulary, they do step therapy, prior authorization, and all of that on the pharmacy side. But on the managed care side, I think disease management, which was kind of it didn't have the best kind of brand around that concept. Today, chronic care management is like a part and parcel of managed care. And a lot of that does involve compliance with pharmacotherapy and so on. So there's been kind of a convergence of what the PBMs are doing and the managed care companies are doing, and makes it more seamless to have it under one organization. To manage a member's health, to reduce admissions and readmissions is heavily about compliance with pharmacotherapy and managing their health around the medications that they take, especially for multiple comorbid conditions.
A question, Paul. What about the recent hostility towards PBMs in the federal policy world? Is that a factor that these companies are looking at and trying to protect themselves from?
I think they're certainly responding to it and sort of anticipating changes in the potential changes in the rebate structure and the sharing of rebates with the patients, maybe under Medicare Part D, if the Trump administration goes ahead and proposes that. So some of that's they're already starting to do that with customers in the commercial marketplace. And so they're definitely anticipating changes in Washington and being proactive on the commercial market side.
Yeah. So was this a factor in some of the vertical integration, or did it just come up at the last minute?
Hard to say. I mean, it might have played some role in, for example, prompting Express's willingness to sell to Cigna. Would be my speculation.
I think CVS partly. I think CVS inked their deal, or they were in discussions in October of 17. And that was when the whole Amazon threat had started to really, hit the whole drug supply chain and the retail pharmacy business as well. So then Aetna CVS inked the deal in December, and I think it beyond the imperatives we talked about from the point of view of just managing healthcare better and patient quality and outcomes better, these threats from outside prompted CVS to do something, and then Cigna was sitting there, their deal with Anthem had broken, so they're looking for something to do, and simultaneously you started hearing noise from Washington around the PBM role and the margins and the middleman and the role of the middleman. I think it all kind of came together.
It's sort of interesting. I mean, I think we talk about the risk to PBMs, but there's some opportunities to PBMs as too, as Anna was talking about, playing the middleman in Medicare Part B, potentially, maybe through their specialty pharma.
Yeah. Good points. Now I'd like to move on to the second type of vertical combination, which is the acquisition of medical practices and freestanding outpatient facilities by insurers. And some of the examples would be what Optum has been doing, what Florida Blue, to a lesser extent, has been doing as far as acquiring practices. And initially, I perceived these acquisitions as motivated by insurers' desire to keep the practices from being acquired by hospitals, but now perceive it as a much broader thing and having additional strategic goals. So explain why we've, please comment on that, and you may also want to explain why we've seen very little in the way of insurers acquiring hospitals in contrast to their very extensive acquisitions of physician practices. Yes.
Maybe I could take a stab at that. I mean, recognize, of course, that the managed care companies are not pursuing a uniform strategy here, and that, some of them, you'll hear maybe not so much publicly, but they will say, look, we did that, 20, 30 years ago, and the results weren't very good. We're not going to go down that road today. That's not the consensus necessarily, but that's certainly, more than one opinion that's out there in the industry. On the other hand, clearly at the other end of the spectrum, you have United Health that has been, very acquisitive and done many acquisitions of providers. I would comment that bear in mind, and I'm sure, by the way, that a defensive objective is part of this, to not have hospitals acquire every practice in a given market. Excuse me. But bear in mind the difference between the, let's say, Kaiser Permanente model of having the doctors under the roof of the plan and captive to that plan, if you will, serving only Kaiser members. What United and Optum have done is acquire practices that are multi-payer and that remain multi-payer. And United's intention is very much to keep them multi-payer, and in fact, that's true across generally across the spectrum of the Optum providers. MedExpress, for example, their urgent care centers operate under the same model, and that probably makes sense if United is going to continue to be a broad-based, network contracted health plan that appeals to a wide potential customer base, but also raises some of the same possible conflict of interest, I guess you might say, with the, United owning the practice and the practice serving, perhaps 25% of their volume is United and 75% of it is other payers.
I guess I could just, build on what Matt is saying. I think it's more, as I think you may be alluding to, Paul, it's more offensive than defensive. From, I think, United's angle, two things. One is you want to reduce hospital spend in your own managed care business, and hopefully as they have a vision that they service other third-party plans for others as well, so improve your, medical loss ratio, which is the percentage of cost spent on, premium spent on costs. And where is the spend? The spend is in hospitals. And they have had this vision of not just moving healthcare costs out of the inpatient setting into the outpatient setting, but just creating a very robust ambulatory access. And that's, their vision is in 75 target markets. They will build out home health. They'll buy up the primary care docs, and that's a huge piece of it because primary care is the linchpin of, managing a member's health. Then you have freestanding urgent care centers, which is under the MedExpress brand, and then the ambulatory surgery centers. They bought a company called Surgery Care Affiliates, and then they have some hospice wrapped around it, and they're trying to integrate data, clinical and claims across all of those sites of service and develop out those markets. And they're having remarkable success. They claim that they're seeing a remarkable mix shifting of emergency room visits, which are high spend, into urgent care. And then a lot of elective surgeries and procedures are being able to be done in the ambulatory setting. And they're keeping people, healthy and all that. So it's that. So it's medical loss ratio and reducing costs. But I think they also looked at it and said, hey, I mean, the economy, the healthcare economy is 3.5 trillion, 3.3 trillion. And you are capped in how much you can grow if you're just trying to grow your insured membership. And this way, they're able to really get, a growth rate that's pegged to the growth of the overall economy and where it's growing, which is in the ambulatory setting, and it's aligned on cost, quality, and outcomes from the point of view of the government, employers, and the member, and they can make a nice revenue growth and profit on that. I don't think it succeeded in the old days because there was no. I mean, where this works is payer mix. Payer mix is important. It's working the best, I think, in Medicare, to a large degree. A lesser degree, I think they're able to optimize payer mix across commercial Medicare and Medicaid by site of service. So that's a big one. And then you need local market share. I think, the old, I guess, view of some health plans where they're like, we won't do this, is they don't have enough Medicare patients and they don't have enough local market share to be able to monetize it. And then finally, they don't have enough cash flow, I think. I think a big part of why Cigna and Express have merged and, CVS and Aetna merged. I mean, eventually CVS and Aetna will pay down their debt, but particularly Cigna Express, which should do it more quickly, they'll have more cash flow. United has $15.5 billion in cash flow from operations this year. You might have all the vision to buy docs, but can you afford the valuations when United Healthcare and then on a defensive basis HCA as a hospital are competing with you? It's been hard for Humana. They want to buy more physicians, but they now are just building it out organically because they say the valuations are too stretched.
Oh, go ahead,
I was
Paul.
just going to say, certainly government policy and on the commercial payer side, more and more procedures are shifting into the lower cost ambulatory surgical center. Medicare has been moving in that direction, and on the commercial side, they've actually started, I guess they've been doing for a while, total knee replacements. So Medicare isn't allowed payment in a surgical center for that yet, although they're allowing it in a hospital outpatient setting, but they're moving in that direction.
Yeah. So
Paul, could I just make one?
Oh, sure.
I just want to build on what Anna said about the cash flow, and recognize that a lot of this really is about United Health Group rather than the industry overall. There is certainly activity with integration, but the lion's share of the acquisitions have been driven by the largest company in the industry, which of course is very important and enabled by the huge cash flow that they have, which is not to say that there isn't financial strength at the others, but it is an order of magnitude larger. I think the question here, where I think we can say the jury's out, even though it's clearly United continues to be successful, but are you better off owning MedExpress urgent care centers as a means of reducing emergency room utilization, or can you do just as well or maybe better by contracting with urgent care centers and doing it virtually? And of course, just to add this point too, which is despite the scale and volume of the acquisitions that United has done, it's still the case. It's only around the own providers who've been acquired by United cover about 15% of United's insured medical expense. So enough to absolutely move the needle. It's significant, but we're not talking 50% yet.
Yeah, I would think strategically some of the potential upside might be in actually changing the behavior of the physicians that they control, particularly primary care physicians. And have they actually had any success in doing that, or are they at very early stages and just kind of acquiring the assets and not figuring out how to influence them?
Well, remember, this is where we as analysts covering these companies try to get visibility on those things that are 2 levels down at an operational level, but it's limited. So, certainly it would be a lot more likely that they've had success with those that have been 2 or 3 or 4 years under their ownership than the ones recently acquired. I guess from our perspective, I have to say it makes sense. The jury is still out. The one other point, though, that's important is compared to, let's say, 15 years ago, there's a lot more bang for the buck in terms of medical cost reduction in the IT investment. So if you own the practice, as an insurer, you're able to capture some of the return on that actually wouldn't go to the practice, because it's, it might if they're under a comprehensive risk contract, but if they're reducing medical expenses because of their IT investments, that's something that they can and their insurer parent can benefit from if they're under the same roof. Whereas if they're an independent, thinly capitalized practice, they may not be able to make that investment. It may not make sense.
That's a good point. And I guess another thing is that to the degree that they're investing in the IT and to change physicians' behavior, they're still sharing a lot of the gains with their competitors who are also using those physicians.
In theory, right?
In theory,
I don't
right.
mean to be cynical. I think that's another point where I guess I would say the jury's out.
Yeah.
So I think, as Matt says, we are outside in salutes, if you will. So I don't have visibility into what United's doing in their Optum Care practices. But I think you may be coming to this, later. But other companies that don't have United's strength of physicians and not able to do it all themselves do outsource or have vendor relationships with these startup privates now called ChenMed and IORA and so on. So there, for sure, when you think about Medicare Advantage, again, that's where this is really kind of the incentive and the behavior is changing. If it's $1,000 a month per month per member premiums, the Humanas and WellCares maybe even of the world, but I think what I hear from these private companies, CEOs, is that they skim 5% profit, 10% they take on G&A, which they use for their administrative expenses, distribution, sales, and marketing. Then you kind of have that 85%, medical loss ratio pot. And they give that to the outsourced vendor, relationship. Now, if they come in at 65% because they ended up doing such a great job of managing all these seniors who showed up at their door, they get to pocket most of it. Well, that will change behavior pretty quickly. I don't know whether United is that generous with their internal physicians,
Yeah.
but then.
Oh, good. Well, it gets us into our next question.
Probably not.
Which is, although not vertical integration, I'm struck by the degree to which physician practices are being acquired by private equity partnerships or funded by venture capital. And some of these have become publicly traded companies. So you started talking about this, Anna, but what is the attraction for private equity in this area? Meaning, what opportunities does private equity perceive to make more money from the practices than the practices are making today? Because isn't that the essence of the strategy, that if you can't make more money with these practices, it won't work?
Well, but maybe you don't have to make a lot more, because maybe what your objective is to have it make a little bit more and to have the value of the practice increase because of that, but also because the value of practices is increasing generally, and sell the practice 5 years down the road and reap some considerable profit. I mean, that we don't know exactly what the perceived end game is for some of these acquirers.
I guess from the practice perspective, though, what is the life of a onesie twosie primary care practice today? You don't make that much. You don't make that much just doing fee-for-service based treatments right now. The whole back end of billing, managed care, and all is very challenging. If you're trying to move to value-based care, there are scale and scope economies of being able to do that. And the world for primary care is, the model I described, that's very attractive. If you can make, a 10 to 15% loss ratio differential because of how you manage that senior, there's a lot of money to be made there. Can you do that as a solo practice? No. So private equity is trying to bring that scale together, at least in primary care. We have other specialties which have different objectives, where you can roll up all these primary care practices and have a methodology to how you're doing the chronic care management, and each one of them has a different recipe. IORA has their recipe, ChenMed does their thing, Agilon does their thing. You know, Bright Health is doing a completely different thing, though they don't do it with primary care practices. They do it with health systems.
Yes.
But they're all doing their own thing, and there is scale and scope economies. And then there's a lot of appetite among the public, investing community to really see IPOs, and they want to invest in this. So it's a great exit for private equity, or they can sell it to a United or a Humana or somebody else, or an HCA even, for all you know.
Can I just make one point on that,
Sure.
Paul, which is just to say, I agree with all of that. The one caveat is just a reminder, which is close to my heart, because I spent most of the late 1990s in what was the physician practice management industry, which many of you may recall had a very fast rise and a very calamitous fall. All three of the public companies exited the business. A lot of private companies, including the one I worked for, essentially became insolvent. So it was incredibly comprehensive boom and bust. Now, we could go back and look at, and I'm not going to try to do that here, all of the factors that were running against the environment of what these new companies were trying to do back in the 1997, 1998 era, and it was a little bit of everything that was could go wrong was going wrong, and now a lot of those factors are running in favor of this model, but still that all made sense in the mid-90s on paper, and Wall Street absolutely loved the idea, and it was a complete disaster in its implementation. So that's just one thing not to forget from our industry history.
I would just add that for the doctors, there's because of the 2015 Medicare payment reforms, there's more risks and more administrative burden.
Right.
Like macro and
Yes.
Macro.
Yes, and so more risk and more administrative burden and opportunity, and based on pay for performance, may also for private equity translate into an opportunity for them to help with the administrative burden and spread the cost and reduce the cost per doctor, and also find them a way to maximize their reimbursement under the pay for performance metrics.
Yeah. So this may be part of an inevitable recognition that small practices don't have a future, and one way or the other, being acquired by insurers, working for a hospital, or being acquired by private equity or another organization. That may be the opportunity set for small practices. Nobody is going into them anymore. Newly trained physicians want to work for a large organization. And so I guess that's just part of the landscape.
Yeah, UAM, Universal American, which was purchased by WellCare, with both public companies, started to help out onesie, twosie primary care practices with the Medicare shared savings plan. So that was their model. It was mixed in success because this whole upside downside risk and the payout was challenging for UAM, and I'm not sure it's played itself out particularly in WellCare either, because I hardly hear them talk about it. But that was something that Rich Barish, the CEO of UAM, put a lot of energy into, trying to keep these onesie, twosie practices independent, but still able to partake of some of the the shared savings models beyond Medicare Advantage.
Good points. Let's move on to hospitals creating insurance plans focused on Medicare Advantage and the ACA exchange markets, and partnerships between hospital systems and insurers to offer such practices. And as you mentioned, Anna, one of the examples is Bright Health. I believe Aetna has done a lot in this area. And if you could comment on how significant those developments are.
So Bright is an interesting model. I think Bright Health doesn't have the primary care practice model, but they're doing this neighborhood care model, which is, as I understand, practically a single health system in a neighborhood. So it's a narrow network where you're creating a joint venture co-branded relationship in every local market with one health system. And you're underwriting risk on Medicare Advantage, but you're managing the costs and outcomes in partnership with that health system. how the economics work for the health system is interesting. I think not-for-profit health systems clearly are more willing to go down that path, because you do end up emptying beds, even though you might drive more volume through your your physician workforce and all of that. But it feels like they are in a good place. I do talk to their management on a regular basis, and I think they sound like they're doing well. Actually, Centene is an interesting one, because more than Aetna, and Aetna has tried to do this with all of these large, flagship pioneer ACOs, I guess, Banner and, others in Virginia and North Carolina and so on. But I don't know how much success they really had. I think they started to do it with the employees of that health system, as opposed with MA, as opposed to with MA. And I hate to keep coming back to MA, but I think the big difference between now and then, in the 90s, was we didn't have Medicare Advantage, and today we do, and it's a value-based care model that's actually succeeding. But Centene has inked a deal with Ascension, and 26 states. This is a Catholic health system, and they are going to do by 2020 a co-branded Medicare Advantage product across all of these 26 states. Now, it's non-trivial, as I said, from an economic standpoint. It's been tried and not done successfully. But if they manage to come up with a successful approach and grow, I think it'll be a blueprint for others to do as well.
Not to be the curmudgeon party pooper on some of these things, but just another historical precedent here of failed models that recall. Again, I'll go back to the late 90s, or really the 90s, that there were many provider-sponsored, particularly hospital-sponsored health plans that ultimately failed, and there were many factors that went into that failure. But one of the questions was, can hospital systems that have in their DNA, if you will, the objective of filling beds, can they actually do a good job running health plans, and incenting doctors to efficiently work towards managing medical costs? Not to be too wishy-washy on this, but I think the jury's out. There's a lot has changed, and of course there probably isn't one answer anyway. That there are some of these models that will work, and some of them won't. But we're in the middle of an experiment of something that has been tried before, and when it was tried before, it was overall more of a failure than a success.
Yeah, I'm glad you brought that up. I want to go into a fifth type of integration, which is insurance and retail pharmacies. And the examples, of course, would be CVS, Aetna, and a rumored relationship between Walmart and Humana. So if you could comment on, what is the potential strategy, what do they hope to accomplish with this type of vertical combination?
I just offered, and really, initially it was Aetna's CEO, Mark Bertolini, who expressed the vision around this. The idea is to take some subset of the 10,000 CVS stores, in the case of Aetna CVS, and repurpose them towards being, to some degree, neighborhood health centers, and certainly depending on the socioeconomic surrounding, that may be the primary care delivery for Medicaid populations in some cases, but something that would build out from the relatively limited and low acuity level of the services provided by the Minute Clinics. So you'd have more than that. But on the other hand, they were, Aetna and CVS thus far have been pretty clear that they do not anticipate having physicians as part of this model. So, and I'm a little surprised, given that we haven't heard a little pushback from the physician community. But of course, it's still early days for this. They're talking about doing pilots of it after they complete the merger, and then if all goes well, and informed by that, to roll it out more broadly. And clearly, if it works, it has a potential to be a lower cost site of care delivery, particularly with the non-physician personnel. I will make a sort of snide comment that it seems a little backwards for them to be merging first and then piloting the concept, but that's what they've talked about doing.
Yeah, I think it's, I agree with everything Matt said. It's, quote unquote, supposedly transformative, but the existing care delivery model is primary care, and they would have to disrupt that. My pushback would be, I think, couple-fold. It feels like it's coming at it, to Matt's point, backward, because there's surplus commercial real estate, and and CVS has more stores than they know what to do with, and obviously front store sales are going down, and hey, Amazon is always sitting there trying to do retail online fulfillment online, and they just bought this PillPack, and obviously they're not stopping at PillPack. And so here you have CVS worried about what do they do with these 10,000 stores, and here you have Aetna, who's been a little bit of a laggard, I would say, among the large insurance companies in terms of creating any medical cost structure advantage. I mean, their growth has been heavily about just pricing above trend and managing an underwriting cycle, and that's the game that played 10 years ago. You can't play that game anymore with medical loss ratio floors and all of that. The other pushback I would have is, if you build it, I guess, as I said, will they come? I mean, here you have a health coach, a minute clinic nurse who, I've been used to managing sore throats and earaches and all. And they do chronic care, longitudinal population health management, which is the vision that CVS has around this. And then they're talking about engaging the pharmacist. I mean, you've seen the CVS pharmacists. They're so busy, the lines just to fill up the scripts, it's kind of crazy. Where is the capacity to do something like that? So they've put in a teledoc, telemedicine terminal is their vision. So they've inked a deal with Teladoc to try to bring the primary care doc in there through a telemedicine visit. And they have a relationship with Epic on the back end on the electronic health record. But here you have, if you're doing this for seniors, and that's what they want to do, very early stage seniors may want to look at telemedicine and health on their phone. They don't need to drive to a store. By the time you're 75 and above, do you want to drive to a store? I think the virtual home concept is the biggest concept right now. And Humana is investing a ton in home health. They just bought a portion of Kindred at Home with the private equity consortium. United is investing a ton in home health. Home health is exploded as far as Amedisys and LHC and the others are all circling around. Private equity wants to get into home health. So, the jury is very much out around what CVS will be able to do. Besides which, Aetna has like 10% market share on average, maybe less in many markets, a little bit more in others. Can you monetize this by selling a visit for $100? Not, firstly, how many visits can you do in a store? You make your money by reducing your medical loss ratio. And you'll be selling that visit to the Blue Cross, who's your arch enemy competitor. And so there's a lot of, ifs and around that model. We'll see.
On the home health side, I think it's important to note that the Trump administration changed the Medicare Advantage supplemental benefit structure for next year, and basically are allowing sort of quote unquote non-medical care, including in-home help, to help people with activities of daily living to help keep them out of the hospital. So.
Good. Actually, one thought I had inspired by what Anna said is that I could see CVS wanting to pursue this model, whether it's a good model or not. But I was always baffled by why do it with Aetna? Why do it with an insurer? And the only cynical reason I can think of is that, well, Aetna had the capital, and maybe no one else was willing to come forward with the capital.
Well, also the cash flows. I mean, Optum and United work because United Healthcare generates all of this cash because the insurance model is amazing. There is more free cash than you would ever, see in any other business. They get their premiums before they pay the claims. There's no capital expenditure. Their debt load is low. So I mean, Aetna can fuel a lot of the the maintenance and growth capex for CVS. That's I think why those those two things work together, which we didn't talk about as a reason for these deals, but
that's right. But there's perhaps
Wall Street view of it.
It's a great business while the margins hold up. and we've been through a long period where margins have been very healthy. But of course, in the past, we've been through cycles where it's not.
Underwriting cycle bear here.
Right. Well, no,
you
no.
did call the 2008.
I just don't want us to forget our
2006.
history. 2006.
He was right.
That was a long time ago.
I worked at Aetna, and Ron Williams is like, this Goldman guy is so bearish. And then they had some hiccup, and I think he was reaching out to you or whatever.
I don't remember.
It felt like you were getting.
Well, thank you, Anna. My point relative to CVS is we'll see how Aetna is as a market participant in terms of its pricing and how that changes under CVS ownership. I have a gut feel that they're going to be more aggressive and not so cautious as they have been under.
I worry about that too.
Yeah.
I know. Hope they don't burst that bubble.
Good. Well, this leads up to a closing question in this, is that putting aside the partnership between Amazon and Berkshire Hathaway and JP Morgan, we'll get to that later, but what do you see as the greatest potential for Amazon in healthcare, if anything?
Well, what do they have? I mean, they have the best order fulfillment. That's the first thing. And then they have technology and an online platform with a relationship with the consumer. Those are their two big assets. So the move with PillPack and the speculation around them entering the drug supply chain is very rational. Why wouldn't they? They do everything else. They can get into food and grocery. They can get into drugs. I mean, you start with OTC, then maybe you do generics. They compete with Walmart, who does $4 and $9 generics, a list of, 500 drugs or something. Why wouldn't they do that? They get and get into it with the generic profit, but you're now drawing people onto your platform whom they shop in your, quote unquote marketplace, in your front store online. So all of that makes sense. Maybe they backward integrate then into wholesaling. That's why the McKessons and AmerisourceBergens and Cardinals have been under pressure as well, because the expectation would be then maybe they have a hub and spoke wholesaling distribution model that's a little more state of the art than some of these, legacy drug distributors. I'm just speculating, and none of us know. PillPack thing we know, so that you know that their entry move was about comorbid conditions and delivering packaged, order fulfillment to people with comorbid conditions, but they're not stopping there. Other than that, I guess, and you said you'll talk about the coalition later, but they've started worksite wellness for their own members, and it feels like that might be consistent with the Bezos, Buffett, Diamond triumvirate and the noise they've made around the healthcare tapeworm and all that. But they're going after, I think, the angst that employers are feeling right now, particularly large employers, self-insured employers, where maybe health insurers have been so taken up trying to grow in Medicare and Medicaid, where there's a lot more lucrative financials, that there's been disappointment and lack of satisfaction among working Americans and employers. So maybe Amazon makes a play there across telemedicine, worksite wellness. That would be another thing. And then I guess, you didn't talk about Apple and Google, but they're doing a lot right now, right? Google just hired David Feinberg from Geisinger.
Mm-hmm.
And so they're looking at doing integrated, and it's a business-to-business model with artificial intelligence and machine learning and data analytics. But they're looking at integrated data and decision support to help other businesses like health systems and other businesses. How can they enable more value-based care, I think, in other relationships as well. I mean, Amazon can try to do a bit of that as well. Apple right now, you can go on your Apple Health phone today. I didn't even realize I can look at my Yale medical records. I didn't realize I could do that, but I can.
Can I look at your Yale?
So all three of those, big tech is coming in. I still feel very bullish. I'm very, very bullish about managed care because I think they're very adaptable creatures of anything. But also, secondly, I would be very surprised if Amazon, Apple, or Google got into clinical network contracts with docs and hospitals. That is a slog. It needs years of work in IT systems and all of that. There's a lot of downside risks associated with getting so involved in driving policy to, to manage health and treatment decisions and all. That's not conducive to the consumer clean image, brand image of the big tech companies.
Well, that's the question, really. I mean, so we're, both of us are, at the core of our industry focus is managed care. And so there's a little bit of a tendency, but with good reason in this case, because I agree with what Anna said, that it makes the most sense that Amazon's going to go to the areas that play to its strengths. Yet Amazon and maybe Google and Apple too, have some potential to be unpredictable. And we had a person from Amazon on a panel a year ago, and with somewhat reminiscent of United Health and maybe even U.S. healthcare way back when, there's a little arrogance, but they said, look, we can get into any area that we want. And clearly in terms of having the heft and investment scale to do that, they can. I agree with Anna about the slog, the difficulty. I mean, the things that make it tough to enter the managed care industry are considerable, effectively, barriers to entry, whether it comes to Medicare Advantage, the length of time to establish strong star scores, the economies of experience and of scale associated with the risk coding. And in fact, when you think about it, the Affordable Care Act has erected barriers to entry in a certain sense by making it more complicated. Therefore, it takes more time to do these things. And yet those things aren't insurmountable. So that's going to be the most interesting area to watch.
One of the things that we have been watching is this, there's this whole notion right now in the healthcare tech community about the digital door, and there's a battle for the digital front door to healthcare. Which portal will they use, and what will be their entry point when they try to seek, access to their records, like I talked about, but not just that, a telemedicine portal and provider. It's like the first step, and then you funnel out and go elsewhere. Maybe also linked to your benefit design, and so it tells you where your network options are, what your out-of-pocket costs are. Hey, I'm in DC, I want to get my knee done. What are my options? And what would be, with my benefit design, and I have an HSA or something, what is my deductible and out-of-pocket cost and all of that. And so you have tech companies coming in trying to do that, and Apple is obviously trying to do it. Google hasn't made a B2C play, but Amazon could. I haven't yet seen quite what they might do in that area. We have employers and brokers trying to do that, on their own. There are little private companies like Accolade and Heal and all, that are helping, like Comcast and other companies to do that. And then you have the incumbents. I mean, United is making a huge push with something that they bought called Rally. And they are determined to make Rally the digital door. And they have their investor day in a couple weeks, and we'll, I'm sure, hear more. But they are building out individual health records, they're saying, accessible to, very large portion, not of just their members, but anyone served by Optum, that, they'll have access. I've seen Rally, and I got a demo from their CEO one day in Boston. He did exactly that. We were going around, meeting investors. And he was showing people this thing which said, well, I want to get my knee done. There were like 10 providers that popped up, the distance to travel, and then he had his benefit design, what it would cost him personally and what the payout would be, but we'll see how that battle plays out. It's, very much where the tech companies want to come in.
Yeah, it's very interesting given the hysteria about Amazon eating all the healthcare system. Your discussion about, where does Amazon actually have a strategic advantage, possibly, as opposed to areas where it clearly doesn't. So, but it's striking about the Amazon panelists not going along with that.
Right.
Yeah.
Right.
Okay, next topic is physician consolidation. It appears that some hospital-based physician specialties, such as emergency physicians, have become highly consolidated into a small number of national staffing firms. How extensive are these consolidations, and what impact is it having on what insurers and patients are paying for these services, including the balance bills to patients? And are similar trends proceeding for specialties such as anesthesiology, pathology, or radiology?
Paul, do you mean just the consolidation of them, or the ownership by hospitals, for example?
I should have said the owner. I think it's the ownership.
Right.
The ownership, but in a sense, it's also consolidation.
Right.
Because if Envision owns so many of the emergency department docs, that's part of the story.
Right. And this is another area where there's a lot in motion. And it is tough to draw conclusions on a broad scale yet. Particularly, if you start with the hospital ownership of physicians, is that part of these hospitals building accountable care organizations and being able to integrate and offer the spectrum of care that's broad and to take on population-based reimbursement.
Actually, Matt, at this point I was just focusing on the hospital-based physicians, in a sense, the ED, and as opposed to the employment of the primary care or others.
Right. Okay.
Yeah.
I can talk a little bit about this. So these are physician staffing, and each, they're different hospital-based physicians for different service lines. So Envision has and largely has been an emergency department vertical, but we have, and Envision had largely, is largely an ED organization, is largely an ED organization. It's been taken out now by KKR, so I'm calling it a was, but it's gone private. Team Health has had emergency department and anesthesia, that got taken out by Blackstone. And I cover Mednax still, which is still public, but we shall see. They have neonatal and pediatric services, and they have some anesthesia and some radiology. So the reason that there's been some roll-up of these hospital-based specialties is there's just there's economies of roll-up on the back end, in terms of the billing, continuing medical education, and it makes it easier, again, to our point around onesie, twosie being hard on the primary care side. There is some efficiencies that these hospital-based specialists also realize being part of a larger organization. It is still heavily unconsolidated, though. So it's not as though, you're talking about, I think 75 to 80% is still fragmented.
I see.
And, you're seeing that also in the orthopedic and the surgical specialties as well, where Surgery Partners and surgical care affiliates under United and USPI, United Surgical Partners under Tenet Healthcare, they've also seen roll-ups, and they've either exited to a plan like United or a provider like Tenet, or you have a Switzerland organization as Surgery Partners tries to call themselves. And there's some efficiencies of being able to build out surgery centers in an ambulatory setting under a corporate umbrella. A lot of them have equity relationships with these, with these surgeons. So they kind of still get part entrepreneurship and some upside and all of that. But that's what they're doing, I think, in terms of the physician staffing story. They've had a huge amount of issues, which is why a lot of them are exiting right now to private equity and getting turned around. They're getting a lot of, lever up debt added to them to turn them around away from the scrutiny of public analysts like myself, because then you're subject to, quarterly earnings scrutiny, which makes it very, very hard for these players to operate. So but the private equity firms want to buy them, and they see the potential to, wait it out, turn them around, invest, lever up, continue to roll up, and then, eventually they'll probably, go public again or whatever. United and Envision have had there are two types of battles going on the ED side. ED is different than hospital-based anesthesia or surgery or whatever. The relationship there is between the hospital and that physician staffing company. ED, on the other hand, is part of it is B2B, where United is having a gigantic public battle on the in-network rate they get with Envision, and claim that Anthem and others are paying less, and Envision disputes that mightily, but we'll see where that battle ends up. But you have had Anthem most recently, and some of the Blues, where they are saying, well, if you have just gone off to an emergency room, and even though that poor hospital has delivered that emergency care, they're saying we won't pay it if we believe it was deemed unnecessary. Now that's a utilization thing where they're going after poor consumers. So I don't know how that, that's not going to last. I don't think it'll stick, but that's just my opinion. That piece of it.
Good. So what you were saying is that, in a sense, the acquisition of by private equity of these publicly traded staffing companies is a sign of distress.
It is, completely. I mean, Envision got taken out for 9.5 times. It's an incredibly low multiple. Team got taken out for 11, and we thought 11 was kind of low. That was like 2 to 3 years ago. But the ED, public valuations continue to get depressed. I mean, I think investors are now looking at Mednax as a value investment. I did upgrade them on that. Is it oversold at this point, and is there enough cash flow generation? They don't put money into building beds and improving their facilities, and also they have a better cash flow profile. So from that angle, they're more attractive than like Community Health, which is like whatever 8 times or whatever it's done.
Yeah, so you'd mentioned United's dispute with Envision, and they're arguing that they're being charged more than others. That doesn't
That's what
sound
they
like,
claim. That's what they claim.
That doesn't sound like a leverage. Right?
Yeah,
It's just
so
saying,
I
hey,
guess,
you can't charge us more than you charge Anthem.
I think what they're saying is if you don't give us the same rate, or we believe and we have heard you're getting a better rate, others are getting a better rate, then as of December 31st, we're going to take you from in-network and make you out-of-network.
Okay.
The question is, does Envision care? I mean, United's big enough, I suppose, to, if they shout loud enough, maybe they get their way.
Of course, the public policy angle on this is in a partisan town right now. The one area of bipartisanship on healthcare is legislation that would address patient concerns about being billed out of network.
Balance billing, yeah.
For
surprise.
Emergency care or anesthesiology when they're in an in-network hospital.
That's more of the Anthem and Blue story than United, which is just fighting on rate. But they're just fighting publicly on rate.
And actually, even though it's finally federal legislation might come about,
There's states.
States have been pretty
acting
far
on this,
along
yes.
in this. Large states, New York, California,
Right.
New Jersey.
Right.
So that might be a factor in influencing the industry. Good. Hospital employment of physicians. How much further, if at all, will the trend go?
Well, this maybe gets back to the question of how well the hospitals can do it. And I think that's, we're in one sense, this has been going on for a long time. It's been a huge and transformative trend if you look at the statistics of the number of doctors that operate under hospital employment. I don't have them top of mind, but it's a major change from the beginning of this decade to where we are now. But as I've said about a number of things here, the jury's out on how well hospitals are really going to do running those physician practices. And again, as these things sort of go through historical patterns, there was a precedent of hospitals doing this in significant scale back in the 1990s in particular, and divesting many of the practices, as it turned out that they didn't do it very well. Now that was in particular in fee-for-service environments where doctors who are in an entrepreneurially driven independent practice style and went to hospital employment, surprise, surprise, they weren't as productive. That was certainly one of the issues. And so the doctors coming out, the new doctors coming out of medical school like the offer of stable employment. That's more appealing nowadays given the entrepreneurial independent practice model isn't nearly as attractive as it used to be. But the hospitals are going to have to be successful with it. And thus far, I think the results are mostly more good than bad, but we'll see.
I would say, I don't know whether this is enough of policy changes or enough of have enough of an impact to make a difference in whether this is appealing. But the Trump administration's becoming pretty aggressive and sort of cutting off one potential source of revenue for hospitals acquiring doctors, where they're basically moving to this policy of site-neutral policy and saying that they're going to doc practices that were off campus of the main hospital were getting reimbursed at the Medicare hospital outpatient reimbursement rate, which is 60% higher than the physician fee schedule rate, and the administration is making policy changes to reduce that in certain areas. And I would think they would continue to be aggressive in that area.
That arbitrage certainly has been something that the hospitals have benefited from in many of these practice acquisitions and employment of physicians. So it's going to take a while for that policy change to ripple through, since there's so many, since the sites are grandfathered, the ones that are already operating, but it will be a change.
Right, and I think the administration is interested in going after the grandfathered ones, and there's a question, certainly American Hospital Association has a different opinion about whether the administration has authority to do that.
I mean, one thing I feel that, and you tell me, Matt, if you sort of see it, it's just a trend on what I feel we're hearing from the hospitals, the publicly traded guys. I feel like they're talking a little less about physician recruitment, which used to be physician recruitment. There was no return from this recruitment, but they were recruiting them, and their salary, wage, and benefits were looking bad, and even community, I feel, has stopped talking about it. The latest buzzword is service line investments. So they're all investing in service lines.
High acuity service
high
lines.
acuity, because everything that can be possibly moved to the ambulatory setting is slowly getting moved to the ambulatory setting. So what you want to do is whatever beds you've got left that are filled, you want to fill them up with the highest acuity and the best payer mix. So that's what they're trying to do, optimize for, the orthopedic service lines and neuro, and that's kind of the name of the game, it feels. Even the little rural guys are saying service lines.
Yeah, they are, yeah.
And we've seen pricing growth, so revenue per admission this year has been remarkably high, even beyond anything you might see in the Medicare rates. It's been more than you would project out just based on the rate environment in Medicare. So the question and the controversy right now is, did we see a lot of whatever could likely move to ambulatory in a big way is kind of getting squeezed out? And if you're a high capacity utilization hospital, like HCA is 75% utilized, you can really place some nice economics with your capacity to put the lower priced ones elsewhere.
Yes, although there's a little bit of an open question here in terms of how much of that, the revenue per unit moving up as much as it has this year, how much of that reflects things like hospital charge master inflation and relatively successful contract negotiations with the payers, at least relative to recent years, versus really, as Anna's pointed to, the mix, so that that as the lower acuity things go out to the outpatient setting, that you've had an order of magnitude change there, and that's now reflected in higher revenue per unit, but it doesn't reflect anything about same store pricing.
Yeah, it's hard to say. I mean, what about bad debt accounting? Is that, you think, a piece of it? Because they changed the bad debt accounting this year.
I didn't think about that one.
I don't know. There's many reasons, but I mean, there's at least a portion of it sounds like it may be service line and acuity. They don't have us.
Well, this would be a good time to transition to questions, and we're getting more high-tech this year. Not only can people raise their hands and ask questions, but people watching online have been sending in questions, and Alwyn Castle can read some of them, but let's start with someone here. I don't think we're going to use the cards, if you don't mind just reading your questions. Yeah, there's someone there.
Here. If you could identify yourself too.
I'm Bruce Steinwald. I have a consulting practice here in Washington, and I'm working with the Brookings Schaeffer initiative as well. With regard to the last topic you just talked about, service lines, I'm very interested in imaging and other advanced testing technologies. As you know, the site of service has changed over the past 2 decades, going first toward physicians' offices and then back to the hospital. I wonder how you see that trend developing further. Is it firmly entrenched now in the hospital? Is it a byproduct of Medicare payment policy? Are there other factors such as technological change at work? Generally, where do you see that portion of the industry going?
I don't have a strong view on that question. It's a little specialized. I don't think anything is that firmly rooted today. So, certainly there's a potential for change, but I'm not sure. Do you have any?
I guess, I agree with Matt. I guess I'm just, whatever I can tell you from the few lenses I see it, at the managed care plans, they started with radiology benefits management, and they've been building out these, these kind of divisions. Like Anthem has this thing called AIM specialty, and they have musculoskeletal and radiology, and they're doing as much as they possibly can outside the hospital setting. And I can't tell you if I don't think they're in early innings of this, if that was your question. I think it's at least mid-innings. It may be late innings, but I don't know. But it does feel like there's still, a push to do as much as they can. Just maybe later innings than surgery centers and ED. I feel like ED and surgery centers have a little more opportunity, particularly surgery centers, because radiology has been going on for a long time. The other thing is I cover Mednax, and they have, their physician staffing company, and they roll up radiologists and radiology practices, and they're trying to move also into teleradiology. They bought a company called VRAD to do that, but they're a hospital-based physician staffing player, and they're investing heavily in teleradiology. So, site of service, whether it's virtual or outside the hospital, seems like it's moving. Moved and continues to move.
Although the policy on radiology, as you probably know better than I do, is somewhat of a barrier to international, outside U.S. outsourcing of radiology services, which in theory might actually make sense from an economic standpoint. Is there, any reason that a, very highly trained radiologist in Bangalore, India, at 1/4 the cost of a US-based radiologist might be able to do the service just as well, or at least most of that service. But today, state laws, I believe it's at the state level, prohibit a lot of that.
Good. There's a question over there.
You've discussed a lot of trends
Could you
today.
identify yourself, please?
I'm Mark Brodsky, retired CEO, who used to pay a lot of medical bills for employees. What's the difference between the U.S. and other developed countries with respect to the trends that you've been talking about today?
Their prices are a lot lower and they spend a lot less.
Because single payer systems will not allow the kind of utilization that we do. How many MRIs do people get in the UK or Canada? I guess.
Yeah, I think that's true, Anna. I would also just add that one of the, if you do a comparison of the U.S. system versus, say, Britain or Canada, certainly one of the things that comes out of that comparison is the capacity per capita is so much higher in the United States. And you can, to take this example, that you can run an MRI machine, and I don't actually do it, so I'll be a little careful with what I say here, but you can run an MRI machine at a profit at 25% capacity. Maybe it's 50% capacity. You don't have that kind of capacity in Canada or in Britain because a lot of the cost control comes from supply side and global budget constraints. So you're going to instead have 100% occupancy, if you will, I should say, not capacity, and you're going to have waiting times in all likelihood as well.
Yeah, there's been a lot of literature over the years, and consistent conclusion is, as Paul said, it's the prices. They actually don't find much difference in the utilization, and part of it may be the queues in other countries versus our price barriers to consumers in this country. The two ways and they wind up at a similar utilization. There was a McKinsey Global Institute study maybe about 5 years ago, which really found what Matt was talking about, the dramatically different rates of capacity utilization, because when the prices are really high, you can make money running it at low capacities. When the prices are squeezed, you have to run at high capacity or you just don't do it. But I think that's pretty consistent and something that our policymakers are going to have to grapple with one of these days, the fact that the difference comes from the prices. Yeah.
Let's take one from Deb, and then I've got one from
Great,
online.
okay.
My favorite Alwyn, of course. When you look at, I'm going to refer to two past policy changes that resulted in rapid change. One is what happened in cardiology after the Deficit Reduction Act with the change in radiology payments where they all fled to the hospitals. That exists in the literature. The second is what happened to physical therapy after the changes in the Balanced Budget Act of 1997. So, if the proposed proposal on drug pricing, which breaks the link between buy and bill, goes through and is finalized, how rapid will the change be? Because history is informative but not predictive.
And can you remind me of what history said? How quickly did it happen? And I didn't
Overnight.
follow that. Really?
Overnight, the for-profit physical therapy chains were broken a month.
Yeah.
I remember. Well, anyway, we'll have to talk about that some other time.
Yeah.
And for cardiology, I believe, according to literature by the former MedPAC commissioner, that was also fairly rapid as well.
Yeah, no, if they can actually get this reg through. I thought when the reg came out, everyone's so focused, connected to the earlier question that was being discussed by Matt and Paul around the international pricing index. I mean, that to me feels like, and I don't know, you guys know way better than me, but everyone in Wall Street has shrugged it off. It feels like it's going to get, kind of diluted down at the very least, if not, and also delayed. But the two other pieces of it, which I thought were the most impactful, got the least amount of attention. This whole notion of switching from buy and bill to flat fee, I think will make a huge difference. If I'm an oncologist and the way I get paid is, 6% of the drug I'm administering, what is my downside in a terminally ill patient to have multiple combo therapies, and I'm making more? I mean, the more I do, in fact, I'll say I tried everything. So it's going to be very, very different if that happens. I think the private sector started doing a lot of that, maybe not all the way, but Anthem, United, and Aetna 2, 3, 4 years ago have started to, give their oncology networks a fixed fee for each patient that they see in the practice, which was quite remarkable. If I remember, it was something in the couple of $100 per patient per month, and then another pay for performance bonus on top of that if they followed certain treatment pathways. And then I think under Andy Slavitt, the oncology care model adopted some of those private sector approaches. And they have, I think, 3,000 oncologists were in that pilot, which translates to quite a number of patients under CMMI. We haven't seen whatever came out of that, but I did think I saw the current CMS, some communication that they're going to try to change and kickstart that, even make it more, powerful and all that. But that, between that and buy and bill, I think going away will be a big thing. And maybe that has knock-on implications, and we haven't talked about this, but rolling up oncology, practices not under McKesson, which kind of, it became a distribution model of getting paid, and McKesson bought US Oncology. And will it make more sense for United and Briova RX to maybe even buy oncologists? And might hospitals try to, kind of take a defensive tack and do something there and employ them as well? I mean, it's going to change a lot of what happens around how drugs are utilized and, what manufacturers will need to do, to manage this huge, big stable of oncology drugs coming in the pipeline. I think it's untenable. Something's got to give. Right now, I mean, when we haven't even scratched the surface of all these drugs hitting the market. If many of them are successful, something's got to give. Buy and bill would be huge, I think, going away.
Paul, and that question from
Great. So this is
remote
from
viewer.
John Cutler, who's watching online, and he would like to know, could the panel talk more about MA Medicare Advantage changes to add non-medical services? Medicare itself has been increasingly covering what one could call long-term care through its current SNF and home health benefit, and this change in policy could impact who long-term care providers and insurers deliver and finance long-term care needs. And I would just add, this is a question about how we medicalize growing old in this country, as opposed to providing the social supports that a large proportion of the elderly population needs. What's the impact of that, I think, for healthcare markets going forward? Are we going to get smart anytime soon?
Probably not, but
Okay.
and correct me if I'm wrong. My understanding is that these benefits that now can be made available through Medicare Advantage generally are not on the traditional Medicare side or through Medicare supplemental policies, right? So, that's the relevant thing for the healthcare markets. You have an environment going into next year. Where it's sort of a perfect storm of positive factors for Medicare Advantage growth. You have a strong reimbursement rate. You have a suspension of the health insurer fee, which is an add-on expense that the insurers don't need to worry about in their benefit designs for or did not need to worry about because it's all set at this point. And then you have this flexibility, and of course you have another somewhat larger cohort of seniors turning 65 who are, yet more likely to be familiar with managed care and less likely to have employer-provided retiree coverage. So CMS has come out with this huge growth forecast of 11.5% growth in the Medicare Advantage population. The companies thus far have said, well, that would be nice, but we're going to stick with our 7 to 8% forecast. And it's going to be interesting to see if CMS's forecast for 2.4 million joining Medicare Advantage actually is what we see. That's going to be a step function higher in the Medicare Advantage penetration. And probably, if that's right, we'll be setting the pace for where we go over the next few years and maybe getting to 50% penetration a lot sooner than we thought.
It seems to me that the administration is using Medicare Advantage, trying to encourage its growth, but using it to experiment. In this case, with in-home services for sort of, loosely described as non-medical needs to avert or reduce medical needs in the future. But they're also doing that on the Part B drug side. Before they announced the international pricing model, they announced sort of more flexibility for the plans on Part B drugs.
On step therapy.
On the step therapy. So I would expect them to continue to do that. And it seems to me that their bias, the Republican bias, and even to some degree, less so. I mean, the Democrats have sort of said Medicare Advantage is here to stay, but the Republican bias is to grow it.
I guess I'm also hearing, in that question something around social determinants of health. Is that sort of also the focus?
Yeah, I think so. I think
okay.
that because the rigid benefit structures don't, other than the home-based community supports for Medicaid dual eligibles, there isn't, there's a significant cohort of elderly people who could do just fine in their homes, but they need help with the activities of daily living. So and we don't pay for that. And we don't
I
have
think
a plan
what
for
I've
that.
heard from WellCare, which has probably the most dual special needs plans portfolio, but also from Humana and others who maybe are not that focused on the lowest income, is that CMS did a little bit in the 2019 bid design to help. Initially they proposed more, I think, and the conversations were more about transportation and food and housing. But then the final rule that came out in April or whatever, didn't go as far as they would have liked it to. All that being said, I think most of the plans are excited that they can include some of that and at least get paid part way because they were doing it but not getting. So this is on pure MA. And then, of course, also, the MMP integrated duals maybe didn't go all the way, but to the degree that they're also ensuring the same, provider or plan is ensuring long-term care, and even if they're not, they are outfitting low-income projects with, wheelchairs and so. I mean, United spent in many towns, in many cities, where they have a focus on low-income, assisted living and so on. They're actually investing in that physically, and then they're all putting together, wraparound care management at the home with social workers and, their own home health aides and so on. But I think it's moving, but maybe not fast enough.
Okay, well, this would be a really good time for a break. So let's take one, and we'll be back at 10:45 to resume.